I'm Dr. Matthew Fay, and I've been asked to talk about the pharmacological management of LVSD. We'll have already gone through the diagnostic pathway, showing how we can take somebody with symptoms and signs of heart failure and make the diagnosis. What I need to do is take you through how we will medically manage that diagnosis. Just briefly, we do need to think about how we will grade the symptoms of heart failure. And for this, we use the New York Heart Association, which grades people from no symptoms at all to severe limitations. A friend of mine, Nigel Well, has made this easy for us to remember by saying that New York 1 is no symptoms at all. If somebody has grade 2 New York Heart Association symptoms, then they'll be able to get around on the flat, so they'll be able to do their shopping in a large supermarket where everything's on an even level. In his case, he states that to be Asda. By the time you're getting into the New York Heart Association 3, you're going to struggle getting the bins out in the morning because of the level of activity that you're starting to notice will mean that additional effort, even on the flat, will make you breathless. And then we have severe limitation with New York Heart Association grade 4, which Nigel would suggest means that you'll manage to get breathless even if you're trying to get to the toilet. So if we think about what we have with a patient who is symptomatic and confirmed to have LVSD, is we need to initially think about their symptoms. To do this, we'll need to start a diuretic. This is usually a loop diuretic, often furosemide, but you may wish to use bumetanide. After we've started to improve their symptoms, we need to have a consideration about the severity of the LVSD. If it is graded as severe, then the NICE guidelines would recommend that they should be considered for an implantable defib. Now, obviously, we don't do that in general practice, so we would need to refer to a cardiologist. At the point we refer to the cardiologist, this does not stop us wanting to initiate and up-titrate preventive medication. And we'll go through that in a moment. There are other reasons, of course, you may wish to refer to a cardiologist. I've listed them on the slide. But essentially, we're looking at people with severe unexplained LVSD, particularly at a young age. If you think there's a cardiomyopathy involved, we need to then make sure that that's followed up. And if we think that the LVSD is actually caused by AF, then we would want the AF to be terminated. And again, we'd need the assistance of our cardiology colleagues. Again, even if we're referring to cardiology for any of these reasons, we should still up-titrate medication appropriately. So once we've considered the degree of LVSD, we need to start our first-line medication. And the pathway now states that we will commence ramipril to make sure that the patient can tolerate ACE inhibition. And then we will go on to Entresto. And I will show you this in a couple of slides, how we will go through that. Once we've got the Entresto in place and up-titrated to its maximum tolerated dose, we would then consider adding bisoprolol. We would add a beta blocker even if there's COPD, even if there's peripheral vascular disease. The only reason we wouldn't wish to add a beta blocker is if somebody has fragile asthma. But other previously considered contraindications to bisoprolol, we are no longer considering. After the bisoprolol, we would want to commence the MRA, usually spironolactone. Spironolactone and Entresto will interact in a way that can raise potassium, so it's important that we consider that, and therefore we have to take blood tests regularly to assess the serum potassium. And we do that at week 2, week 4, week 8, week 12, 6 monthly, 9 monthly, and then every 12 months. If somebody remains on the combination of Entresto and spironolactone, we would suggest that their bloods are checked at least every 6 months. Now, at that point, if they are no longer symptomatic of heart failure, we can just move to routine monitoring. However, if they are symptomatic of heart failure, particularly if they've got AF, or if they're unable to tolerate the ramipril and Entresto arm of our protocol, we should refer to a cardiology service so that they can be considered. Let's not forget that anybody with AF and heart failure should be anticoagulated, and we should discuss that and recommend it to the patient. There are lots of other interventions that we can consider, but again, I would suspect that you'd wish to refer these patients to a cardiology service, although it depends on your competency as to what you may wish to do next. If at that stage the patient is now symptom-free, they're on a good secondary preventive prescription, then we can just move to routine monitoring, and I'll get to that in a moment. Otherwise, we should refer to a cardiology service or the specialist heart failure nurses to discuss ongoing management. So there are things that we can consider. If a patient is started on ramipril or is on ramipril from a previous diagnosis and the old pathway of care, and they develop a cough, we would then think about switching directly to Entresto. We would not consider an ARB in that setting. However, if the issues with the ramipril or the ACE inhibitor are due to renal decline or angioneurotic edema, then Entresto is still not an option. We should discontinue the ACE inhibitor, and we should not initiate Entresto without seeking further advice. One of the big problems we get with patients with heart failure is that they tend to become hypotensive, partly because of pump failure, but also due to the fact that a lot of the medications will also cause hypotension. If this is a big issue, then you could consider using ivabradine instead of bisoprolol. But remember, you cannot use ivabradine in those patients with atrial fibrillation. It has to be used only in sinus rhythm. And again, thinking about the spironolactone, we do see issues in some men that they can develop gynecomastia and even start to lactate. If that is a problem, then we could consider switching to Apellimon and up-titrate that in the same manner. However, if the issue with the spironolactone is elevated potassium or renal decline, again, switching from spironolactone to Apellimon will not make a difference. So what we're trying to do in this new pathway of care is to get people onto essentially 4 drugs, Entresto as a combined preparation. And what we would like people to be on is Entresto, rate control, preferably with bisoprolol, but we could use ivabradine, and an MRA. We want them to maintain a blood pressure of greater than 110, and we want them to maintain a creatinine of less than 200, and definitely no increase of greater than 50% from baseline. Ideally, the potassium should be less than 5.5, although some people may tend towards 6 millimoles. So our new pathway is that we will start with a new diagnosis with ramipril and then move on to Entresto. And this is how we do that, with an increase every 2 weeks. If somebody is already on a little bit of ramipril because of a more historic diagnosis, then we would switch on to Entresto. So we would always do column A first. Then we would initiate bisoprolol, and that's again on the logic of the start low and go slow. So we're increasing by 1.25 milligrams initially, and then 2.5 milligrams as we know the patient can tolerate it. We're aiming for a heart rate between 50 to 60 beats per minute, and we do not want the systolic blood pressure to drop below 110, definitely not below 100. And then we would initiate spironolactone. And again, as I stated, it's important to make sure we look after the renal function, so regular monitoring of the electrolytes. If somebody is already on spironolactone, we need to make sure that we're monitoring the electrolytes about every 6 to 12 months. If we're picking somebody up with a historical diagnosis, then it's important that we start with the Entresto and complete that light column, then complete the beta blocker column, then complete the MRA column to ensure that we try and get to the perfect secondary preventive prescription. For exacerbations, we cover that within the protocol, suggesting that you would want to increase the diuretic for 3 or 4 days to see if that can bring the patient back to their dry weight. If it doesn't, then you would want to discuss that patient with one of the heart failure team or the cardiology service. If it does, then you may wish to consider reducing the diuretic once more and see if they can maintain their dry weight on less diuretic. Remember, these are our parameters. We're trying to keep the creatinine less than 200. We're trying to keep the potassium less than 5.5. We're trying to keep the systolic pressure greater than 100 millimeters of mercury, and we're trying to get no symptoms of orthostatic hypotension. Ivabradine is a relatively simple drug, and again, that's covered on the protocol if we're not going to be using bisoprolol, but remember, we cannot use it in AF. So how do we manage somebody with heart failure in a time of COVID? Because most of these patients will be shielding, and we may find that even though the recommendations around shielding have now relaxed, patients are still reluctant to come to our service. First, on the phone, we can actually get some information, particularly if they have a home blood pressure monitor, but we can ask them to talk about taking their pulse and doing daily weights so we can ensure we titrate the medication appropriately. Once we've assessed their basic parameters, we then want to talk to them about their breathlessness. Are they getting much nocturia, which may suggest fluid overload, and therefore we may wish to increase the diuretics as we've just discussed on the previous slide. If they're getting palpitations, then we may wish to arrange for an ECG, either a cardia tracing or a 12 lead at the practice to make sure they've not gone into atrial fibrillation. And if again, they've got increasing peripheral edema, then we may wish to consider what their diuretic status is. Once we've considered their symptoms, and they may be symptom-free, we then get back to the need to ensure that patients have a good preventive prescription. Patients with heart failure die with the same prognosis as somebody with untreated lung cancer if we don't get appropriate intervention in place. So once we know that they're hemodynamically stable, once we know that their symptoms are reasonably well controlled, then we need to ensure that their prescription is as good as we can get. If we're struggling with that, we may wish to consider referral to the heart failure nurse specialist service. Don't forget, when we're dealing with patients with heart failure, that they may also have high risk of vascular disease. So ensure that we do the basics, making sure their blood pressure is controlled, AF is anticoagulated, and of course, if they're smoking or have poor lifestyle, we address this as well. Many patients who have heart failure will have a statin, even though they're not known to have vascular disease, because heart failure is a sign of end organ damage. So what can we do when we have contact with the patient? Always encourage good lifestyle, always encourage activity. Take the opportunity to get people to stop smoking, review their cardiovascular risk, ensure they're on an aggressive preventative prescription to maximize their risk reduction, watch out for side effects, and try and always support adherence. Thank you for your time.